Attention on deck. Good afternoon, Colonel Keyes, Captain Austin, Master Sergeant McQueen, Walter Reed, team and family, and honored guests. My name is Captain Juan Rosario, and I am the Chief of Staff of Walter Reed. Today, we are honored to welcome Mr. Darren Selnick, performing the duties of the Undersecretary of Defense for Personnel and Readiness, and Dr. Stephen Ferrara, the Acting Assistant Secretary of Defense for Health Affairs. This is a unique opportunity for all of us at Walter Reed to hear Mr. Selnick and Dr. Ferrara speak and engage directly with the staff, all of you here, during the discussion period immediately following their remarks. So, without further ado, you guys have been waiting for a while. Mr. Selnick, Dr. Ferrara, the floor is yours.
Thank you, thank you. Before I start, Dr. Ferrara, did you have something that you'd like to say?
Well, again, I'd just like to say, first of all, thank you to Mr. Selnick for coming. And it's great to be back here at Walter Reed. For me, this is, many of you probably know me. I've been on, working here for probably about 11 years as an interventional radiologist. So I feel a very, close association. And when at any given time, I, was in the audience. So it's, great to be here, great to have the opportunity to help lead the military health system, which has been the defining, really, institution of my adult life. So it's wonderful to be able to be here and help, work through continuing what our mission is, which is, providing outstanding care to the warfighter and improving our ability to, to fight and win, and then also making sure everybody has the skill sustainment they need, and that we can continue to strengthen the chain by our fourth generation platform, which the National Capital Consortium is the largest one in the military. And it's really, here at Walter Reed is the hub, but we have, multiple other facilities that rely on it. So again, it's just great to be here and look forward to a great discussion, most of all.
Thank you, thank you. Well, it's a pleasure to be here today. I was here a number of weeks ago after the steam pipes broke. And so today's not going to be a traditional speech. I don't have a speech. They gave me some talking points. I always like to look at them and then disregard them. But they're good as a reference. And I do have some props. I always like to have props. I did have some notes I wrote down of things I want to make sure I cover. But the reason I'm here is because, number one, I learned as a young officer, and I'm a retired Air Force officer myself, and I am a patient at Camp Pendleton. It's where I get my health care, the TRICARE Prime. My wife's been a patient there as well. My kids were born in military hospitals. Probably the most scenic one was over at the Air Force Academy, where deer are nibbling on outside the window as your baby's being born. My wife was not very happy, though, because it was early in the morning and the doctor and I were focused on the baseball game repeat rather than giving her birth. But things have changed in healthcare. To give you an example, when I was a young officer in 1986 at Shepherd Air Force Base, my wife had something on her back that needed to be cut out, really small type of procedure. I said, great, I'll wait in the hallway. The doctor said, not so fast, Lieutenant. You're going to be my nurse, and you're going to help with the procedure. My wife's jaw dropped, and I said, what? And yes, I got to help with the procedure. We don't do that anymore with staffing shortages. So things have changed, but just a little bit about me and my philosophy. I do have a healthcare background. I did not do that when I was in active duty, but I did do that afterwards. And worked for some major HMOs. I spent 9 years at the VA in a variety of assignments, working for a number of secretaries, special assistants, senior advisor. I helped do the overall the VA healthcare system. Everyone thought I was so smart, but I kept telling them I was just modeling them after the military healthcare system. Have you heard of a thing called TRICARE Prime? I would tell them. So that's where I would borrow things like the access standards and whatnot. And I, like I said, get my care at Camp Pendleton, which has been a great place to go. Even during COVID, I was able to go ahead and get a community provider within a couple of weeks when I needed dermatology. But Newt Gingrich had a saying, and his saying was, you have to be careful because are you an island in a sea of mediocrity? And he used that to describe the VA. And we want to make sure that our healthcare system does not break down, because we do have islands of excellence. But the goal is not to have islands of excellence. The goal is to have everything being excellent. And so there's a couple of things that always guide me, because I am also a veteran advocate. I'm a healthcare advocate. And when you do the right thing, you get a lot of fake news and that sorts of stuff. But there's always been a couple of things that have, quotes that have kind of guided me in terms of doing patient care, in terms of taking care of our military and our veterans. One is from Teddy Roosevelt. And it says, a man who is good enough to shed his blood for his country is good enough to be given a square deal afterwards. And so part of being on active duty is your health care. And your health care is part of that square deal. And part of after you retire is that health care. And if you don't give the square deal, you're going to have recruitment problems. You're going to have retention problems. So we always have to make sure, and that's what advocates do on the outside, is in congressmen and whatnot. We have to make sure we're doing that square deal afterwards. But to operationalize that at a healthcare facility, I kind of go with General Omar Bradley. In 1947, he had to take care of a difficult post-World War II VA healthcare system that needed to get organized and had a lot of challenges. And he said, we are dealing with veterans, not procedures, with their problems, not ours. And that's about being patient-centered, patient-focused. And Captain Austin, we've been talking about how she's been overcoming and trying to focus on taking care of their problems, not ours, and not procedures. So that's important. The other thing that I've been trying to get better in the building is that the understanding and the tying directly of that healthcare is mission readiness. What you do is very important. If our men and women service members and their families are not healthy, then you have chess pieces, we actually don't have battleships that have sailors that command them. Who's going to push the button? You know, when we talk in the building about moving those chess pieces and how long people's tour has been extended, they have to be healthy. And if your family's not healthy, how much is your head going to be in the game when you're on that battleship, when you're on that destroyer? And I was recently at Guantanamo, and you don't want to be spending too much time inside those facilities. Although there's a lot of people that do extend because they like to scuba dive, and they have some nice facilities there for the permanent residents. But the not so permanent residents like KSM, no, I think I'd rather be someplace else. But some great stuff over there. So understanding how important your mission is. Now, I learned as a young officer that the way you find out what's going on is you go to where the action is. You are where the action is. And unfortunately, Camp Pendleton, not every facility is as good as Camp Pendleton. Although when they did have a temporary staffing shortage and my access standard was not met, I went all the way to the top and asking about why was their access standard. Now, very few patients would know what an access standard is or know what the DOD access standards were. But I went to the head guy and I said, hey, this is not acceptable access standard. They had a scheduling problem, and he agreed, and they fixed it. So it's not always the problem, it's the fixing. So as we go forward, we want to make sure that you have the resources to do what you need to do, that your hospital commander has the resources. And it's easy to complain, it's easy to take social media, and social media is important, and we find out certain things through social media. I found out by social media that Captain Austin, although she had a good plan, was not necessarily getting all the resources that she needed. And then I instructed Dr. Ferrara, who's very good at finding resources, kind of like, if you remember the old MASH TV show, Radar, getting stuff like that, and he found the money to start getting stuff going. But the fix is not just steam pipes. The fix is not, and we have maintenance, we have $10 billion in maintenance issues across the entire system. What's best for our patients? What's best for our servicemen and women and their families? What's best for our retirees? What's best for the employees? How do we get there? And so as I've talked to Dr. Farrar and I've talked to staff, it's not about the 6-week fix. It's about the permanent fix. We want Walter Reed to be the premier hospital. We want people to think of Walter Reed as the way they used to think of Walter Reed. We want people to think of Walter Reed the way they think of a Mayo Clinic or a Cleveland Clinic. And we can get there. But it takes time, it takes energy, it takes persistence. And it takes the dedication of all the staff. So if there are problems, you have a chain of command, and we don't want to hide problems. I ask for people to tell me the problems up front. I can't solve problems if I don't know it. Your hospital commander can't. You have to have a climate, though, and it's your commander's responsibility to make sure that you have a climate where you can challenge the status quo appropriately, where you can bring up the problems, where they will get addressed, and where you don't have in some institutions in the government where you're considered a bad person because you are identifying things that need to be improved. You have to have that improvement climate. That has to be rewarded. So we're looking at the long game here as we talk to Congress. You have a secretary who, as one of his special taskers that I've given to Dr. Farah, is how do we reform and improve the DOD healthcare system? We have to be looking at the long game. How do we not make just Walter Reed? How do we make all of our hospitals premier hospitals? How do we make sure that every choice is a good choice, whether you're going to an MTF or you're going to a community care provider? How do we make sure we're looking at how we best take care of the needs and look at a whole variety of options that we haven't looked at in the past? And that's what we're doing with the DOD and the VA and the VA JAC. You know, how do we do things? How do we be more efficient? And how do we redirect that money into our warfighting capability? Because that's what it's about. It's ultimately the mission. And there's lots of different ways to get to the mission. But if you're demoralized because we don't have a war going on and you're not sure what your mission is to make sure that our warfighters are all time ready to go, that their families are healthy, that their minds in it. You are readiness. If we do not have health, I'm going to give you a quick example. In 2017, when I was working at the White House, and that's always a long commute to my doctor at Camp Pendleton, let me tell you. But I would make my trips out. I had a knee problem come up. And everyone's like, oh, well, now, you're getting kind of old and knee problems are normal. But I'm like, I'm a runner. I don't like not running. I don't like cross training. I like to run. And so I went to physical therapy at Camp Pendleton. And I went to my doctor, I said physical therapy, and they sent me in the bowels of Camp Pendleton to a place I'd never been, like Buffalo Rome. I mean, it's just in the middle of nowhere. And the only people who normally go there are the active duty. And I showed up there and they said, are you active duty? And I said, no. And they said, why the hell are you here? I said, well, I got this knee problem. And they sent me there. And they had a gruffy, I think she was a civilian, physical therapist. And she looked at my knee and she bent it and put me in pretzels and figured it out. She said, I have a solution for you. If you follow this solution, 100%, I guarantee your knee problem will go away. Because in the Marines, you have lots of knee problems, lots of backpacks, lots of jumping, Colonel Diggs, lots of knee problems. I followed it to the T, and I have not had a knee problem since 2017. That is success. That are people who know their job. And no physical therapist in the civilian world would have known to do that. I have good physical therapists. So that is the key as we go forward, is knowing your job. It's going to take teamwork. You have to have the patient experience. My wife's been treated like a queen there, great patient experience. You have algorithms, but we also have challenges with the community care. And so as I've talked to people, we've seen that with the community care, the private sector care does not necessarily have the access we need, does not necessarily have the clinician. So it always has to be a good choice, whether you're going here, whether you're then sending them out because the best doctor is actually in the private sector. And then those private sector have to be vetted and they have to be a good choice as well. So let me give you a little example of what I used to talk to town halls that I've kind of translated to you guys about the importance of what you do every day and how you impact the lives that you impact. And you may not even realize it. Like teachers don't realize the impact they have. Every day you see patients or you contribute to seeing patients and you make a difference in that patients. And sometimes you see so many patients and so many people, you forget about the difference you make. And so I used to talk about the boy and the starfish story. And so the boy is on the beach And he sees all these starfishes that are dying because they're not in the water. And so, and it's just covered with starfish. And he's going one at a time, and he's throwing these starfishes in, and a man walks by and he says, you know, there's so many starfish, why are you bothering to throw one in at a time? And the boy says, well, it makes a difference to that starfish, because I've just saved that starfish. You make a difference to every patient. You may not realize it, but when you save the life of that patient, when that patient gets taken care of, and that medical diagnosis, when they get that physical therapy, you are making a difference in the lives of those patients. And it may not seem like it, it may seem overwhelming sometimes, but they know that. And when you're indifferent, and if you don't care, they know that too. And so the true test is, do they want to come here or do they not? And that's what's important. And so I'm here today because I care. I'm here because your patients care. I'm here because you care. And it's easy to not come. It's easy to come by once and never come back. But I'm not here for a photo op. I end up in the press more than I want to, because I sign a lot of things that are controversial. But I'm here because I care, and I like to come back, and I believe in walk-around management. I've had the opportunity, although I didn't do it in the military directly, to do 9 years at the VA, to be on a commission on care, to work on doing legislation to fix things. I knew that there needed to be modernization, but I did not expect the military healthcare system to be adrift the way it is. But we are dedicated to reforming it. We are dedicated to improving it. We are dedicating it to make it the best healthcare in the country anywhere that you go. There should be no islands. There should be no, ultimately, if you've been to one MTF, you've only been to one MTF. We want to do big, bold things. We want to think outside the box. That's the guidance I give. Dr. Farrar is great with that. Your hospital commander, she's getting into the swing of that. And sometimes people are not used to being able to do that. And so there's chains of command, there's rules and regulations, but there are ways to go outside the box and look at, like we had the conversation, is that really a policy or is that just something somebody's been doing? You know, what is the way to get things done? Let's see if I've covered all my stuff. Finish my rambling here. I think we're in good shape. So the bottom line is we're going to turn it over to questions. I'm happy to take any questions you have, but the bottom line up front is you have an important mission. I'm here to support that mission. I'm here to do anything I can. I can't make promises, but I can sure do the good fight with Congress, in the building, because there's always fights and priorities, there are always fights and money, to help socialize the concept that healthcare is mission readiness, is warfighting capability. And yes, it's more sexy to have the best new laser technology and this hypersonic missile and the newest jet and all that good stuff. I always like to say P&R is the most important but the least sexiest organization in the building. Because when the bottom line is you do warfighting with people. If you don't have people, you don't do warfighting. And so let me close it with that. Let me thank you for what you do every day, and let's open it up to questions.
Good afternoon, everyone. I have one question that was submitted earlier, and the question is, how can we ensure the gains made by the rollout of My Military Health / new model of care, such as unleashing the potential of our highest performing individuals and teams, are kept without regressing to the old damaging way of chasing metrics?
Good question. I'm going to answer this at a very high level, and then I will turn it over to you to answer it in more detail. There's always the fear, as you change administrations or you change senior leadership, that gains will go backwards. And that is a very legitimate, and we've all seen that happen. It's less so in the military, because in the military you have a mission, and whenever I would change and rotate, I would continue that mission, but every new leader wants to put their stamp on that. What I can tell you from a high level is that we are here to continue good things and stop bad things. We are here to make sure that things are working and they're working well, and to do improvement, and to do validation to make sure things continue to go forward. So as I've stepped into the seat, I said, no matter how long I'm in the seat, we're going to continue to go forward, and the next person will continue to go forward. That's where I depend on Dr. Farrar as my bulldog here, to go out and validate to make sure we're not regressing. That if things are good. Now, maybe a new initiative, there may be a better way of doing it also. So we're not going to go backwards, but we're always going to go forward. And in going forward, we may do things differently because there may be a better way, and that's what we're rethinking.
Yeah, and I appreciate the question too. And all, Captain Austin is the witness. We literally just were talking about this in the ante room, what I think is getting to the person's question, which is, we form a great team and we start doing something well, and then it's like ebbs and flows, the starfish analogy, the tide comes in, the tide precedes. And so how do we preserve that capability? We start really, cooking with gas, and then people get PCS, people separate, whatever happens, and we lose a capability, and it's very deflating. And so we were literally just talking about that. And that's why it is great that medical is embedded and connected with personnel and where it resides in PNR, because we talk about how do we keep those teams together. I like to talk a lot about, and when we were going through a lot of these personnel things, the healthcare system is an ecosystem. And we need everybody, and everything works as a unit. And that's everybody from the logistician, the admin, the surgeon, and people have heard me tell this story, in order for the surgeon to wield the scalpel, which is how some people think of, the logistician had to buy that scalpel. In order for me to do my procedures as an interventional radiologist, guess what I do? A timeout. I look at the patient's wristband, and I can't proceed until I've done that timeout, that universal protocol. That's an admin person. That's somebody made that wristband. They all have to work. So we're talking about things that where we have the authorities. Mr. Selnick has tasked me with going and finding out the VA has other authorities that we haven't historically had or haven't utilized. What can we do to help keep our teams together so that we can keep functioning, keep delivering that high level of care that we want, that's appropriate for the facility? Here at Walter Reed, there should be nothing we can't do. So we want to be able to do that, but it's going to take all the right people, and that's everybody from whether it's the transplant surgeon, again, to the person, in the blood bank who's doing all those things. And we know all those people. So we're really looking at our policies and procedures and the way we do our staffing to do that. So we're right in line with that, and we want to do that.
Thank you for that answer, sir. I have one question coming in from our Teams chat, and the question is, I accepted my deferred resignation in the Fork in the Road offer on February 6th. It's been 1 month, and there appears to be no communication for those of us who have expected to be completed by the end of last month. When can I expect this process will be completed and that the commitments made by OPM offer completed? Thank you.
Couple of parts to that question, and that's, we should do some follow-up to find out where we are in the status of that. So in the deferred Fork in the Road program, there's actually two parts. Part one was for people to self-identify what they wanted to go and take the generous deferred benefit. But the other part was we had to identify who was mission critical. If we have one doctor at a facility that's in a skill setting that we can't let go, then that was the second part. So who wanted to go, and then a process of identifying who we can go ahead and let go. So there was never a guarantee that if you put in that you would get it, and it has been going slower, but on purpose, because we didn't want to make mistakes. We didn't want to, if we had a warfighter that needed to be there, we didn't want to let it go. If you had a key doctor, you just couldn't let him necessarily go. So we've been asking each component and the DHA overall to identify in this process who are the critical mission people that they cannot let go. And this is nothing different. We've had stop-loss programs. We've done this historically all the time when we've had these early outs and stuff like that. However, having said that, though, we should be at the point where everyone should be being notified that, yes, you put it in and now it's been accepted, versus, no, your critical mission. So I will ask Dr. Farrar to do follow-up on that and find out for all of DHA and for Walter Reed, where are we in this process? Why haven't we, at this point here in March, because I believe the original timeframe is passed when we were supposed to have identified everybody. So we will follow up. That's a very good question. People shouldn't be in limbo. They should know one way or the other, and we want to do that as fast as possible.
Thank you, sir. I have another question coming from Teams. However, folks, remember, we do have microphones available for you if you want to come up and ask the questions here. We have a question from the crowd.
Yes, sir. Thank you very much. I'm Lieutenant Colonel Sarah Reynolds. I'm a pediatric endocrinologist by trade and now get to work in graduate medical education. So I very much focus on patient care and force generation. My question revolves around the part that in the clinics I've worked in, we're having difficulty with clinic right of first refusal, as well as civilian care recapture. Our patients disappear and we can't get them back. From the higher level, including TRICARE and TRICARE rules, what's the talk about making an incentive from an insurance perspective for people to seek care with us when we can provide it? Thank you.
No, thank you for that question. That's one of the things that I've been talking with Dr. Farrar about. It goes back, fundamentally, it goes back that if you want to keep your patients, they have to want to stay here. Financial reimbursement and those same things, we need to do a better job in that as well. I remember when I first was under the TRICARE Prime system myself, I was, it was during the wartime, and I was 100% in the community. I then went to Camp Pendleton. I was 100% in the community, and then they did a recapture program. And the recapture program was basically, if you wanted, once you decided to change providers, they would snag you back. I can tell you as a patient, not knowing that this program existed and not having been at Camp Pendleton, that at first I was very upset as a patient because I was in the private sector. All my care was in the private sector. I wanted to go to another private sector doctor, and then I'm told, no, you have no option. You have to go in there. Fortunately, the care was very good at Camp Pendleton, so I got over it. But I got to tell you, I was initially very resistant to that. So we want to keep our patients. The best way to keep our patients is to do a good job. But there's also patient education and understanding about what the co-pays are if you don't use the system, like pharmacy and those sorts of things. Patients, if you're a retired military, for example, you can, if you don't like Walter Reed, you can do the PPO. That's going to cost you more money. So patient education is very good. But we do need to better continually improve our systems in terms of capturing money from the private sector, secondary payer, and those sorts of things. VA is incentivized to do it, but what I want to be careful in not following the VA model is that they look at that as their overall budget. And so it doesn't do us a lot of good if we have a $60 billion budget, we capture $3 billion, so now we have a $57 billion budget. So we want to make that additive and being able to reinvest. Any comments from you?
Sure, I think, and as a specialist, as a pediatric endocrinologist like you are, I think when you talked about ROFRs, there's at least two factors, there's probably more, but there's one, and non-attributional, just knowing writ large, your healthcare operations team has to have the tables right, correct? And that's back to what I was talking to. People know, in general, not referring to your clinic specifically, but is pediatric endocrinology something that the community and that the referral base is expected, knows that we always have? Because sometimes we go in and out, so the referral patterns change, and then people think, oh, well, they don't have that there anymore, so they just start sending it out. And then does the ROFR table get updated? because that's something that we can own, that we don't always do the best we could. So there's that. And then there's the ERMAC, so then we get the table. And so for those of you who don't know me that well, you know, every night when I have dinner, I'm sitting at 59 years of uniformed services, 8 deployments. I'm a military spouse, a dependent retired, so you're my healthcare benefit. So this place has to be good. I'm a stakeholder. And I hear, my wife is at ATAMC today, where she's a pediatric nephrologist, and they booked cardiology patients into her clinic. I heard about it at dinner last night, today. And they do this every single week. She is in the habit of looking ahead and rescheduling her own patients because our appointing system is not as good as it could be. So that's the other, so there's a push and a pull. And I have talked to DHA, I've directed them, they have to make this better because we lose those patients, which it fragments their care, it's discouraging to you. You came here, you want to see these patients, you want to take care of these families. We want you, the families want to be seen by you, and we don't make it as easy as it could be. So I feel empowered because I know it, I hear about it, I understand it, and we're working on making it better. And we're working on other platforms to, you know, we compete with US Family Health Plan for Johns Hopkins where they have an app. The patient, you know, can do an app to appoint to you, right? We don't have that yet. We're looking at those kind of, you know, those are things that, you know, that Mr. Selnick sees us do, Mr. Hurst sees us do, these digital solutions. So I don't have a solution for you today, but I definitely can say I have a very keen understanding, and I have directed DHA's healthcare operations to figure out they need to fix some of the things that we can fix on our end. And then I would ask at the MTF level in your healthcare operations team, you really got to make sure those ROFR tables are up to date.
Yeah. I want to add, you made it really, no, go ahead and clap for him. Clap for him. But he made a really good point, and that is technology can be your friend. And you have a younger population comes out, they expect that technology. If you don't have the technology, they think there's something wrong with you. So the self-service technology, the apps, and sort of thing. But the important part of that is that can help your productivity. That can make your life easier when people can self-schedule, when they can, you know, and I use the EHRM, I use the patient portal, I check my records. We have a lot of things that need to happen, and we're better than other government organizations, but we're not quite there with a lot of the private sector. And we need to constantly be a learning organization that manages best practices, and at the same time, that's where I'm talking with the CIO and stuff like that. Do we have the budget so that we can constantly upgrade and modernize these technologies to improve patient satisfaction, but also improve your ability? It's the same thing when you're at 11 patients per day, but you're supposed to be at 20 for primary care. Why is that? Is it the number of exam rooms? Is it, you know, the technology? When I see private sector doctors for dermatology, they got the iPad, they all connected, they're in. Their 15 minutes is more than they need because they're just going boom, 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 they already got it, stuff like that. So how is the technology helping you? How is it helping the patient? Those are the kinds of things that make patients want to come to you, stay with you, wait longer if they need to, drive farther. So there's a lot of things to consider, and that's why I'm so lucky to have Dr. Farrar in the position he is, because he's constantly thinking on these things, working this, building the team to do that. But healthcare is always evolving. We're never static.
Sir, thank you for being here. I'm Major Kim Fabian. I'm a pulmonary critical care physician and an associate program director for the internal medicine residency program, which is one of the largest graduate medical education training programs in the military. One of the reported priorities of the Pentagon is medical private sector care. I'm curious if you can explain what you envision or see that entailing, especially in light of your answer to the last question. And then, in addition to that, if you could describe any implications or impacts that you see on the graduate medical education training pipeline.
Right. So we have to be looking at what is the best for the patient. And in terms of what's best for the patient, how do we do our own readiness? How do we do our own skill sets? How do we keep those going? But also, what is the partnership? What are the tools? How do we properly integrate with the private sector to make sure whatever the patient needs is there? Sometimes you have the skill sets, sometimes you have the access, and sometimes you don't. So when I talk about everything has to be a good choice, it's not a either or. It's not a private sector or the military facility. And that's why we need better integration of patient records and other systems, because that is how healthcare is done today. And we're looking at this being a two-way street, and oftentimes it's not, but there are ways potentially we could make it more of a two-way street. Potentially we could do things like, if you don't have enough patients for a particular specialty, maybe you open your panel up to VA patients. Maybe you open your panel up to veterans and bring in their full OHI. We're investigating all options. I'm not saying we're going to do any of those things. I'm going to say we're going to investigate everything. It is a curious dynamic because to be honest, when we talk about looking at what's on the table and off the table for cuts, for some reason, I don't know why this came before our time. We inherited this, but the MTFs, the facilities, we were to look at an 8% cut. The private sector care, was off the table. I had no idea why that is. I was actually surprised to see that. It didn't really make a lot of sense to me, because we have to treat this as one overall healthcare system, and we need to therefore integrate that system. And so our pushback is that we don't want to do an 8% cut. What we actually want to do is make sure we are properly funded, because we're underfunded in so many areas. And when I ask the question, look, you've had a flatline budget for years. Is that because you're like the most efficient medical system in the country? Or is that because you're underfunded? I mean, like, you're so efficient that you keep finding these efficiencies that your budget just stays a flatline while medical inflation is 4%, 5%, 6%? Well, the answer was, you may be an efficient system, but we're not that efficient. We're underfunded. We've been underfunded for years. We have not been allowed to ask for the money we want to. So we're looking at that. We're looking at how do we properly integrate that to first take care of the needs of the patients. And once again, Camp Pendleton's been a great example for me, because that's their philosophy. It's always the need of the patient. Can they do it? No, we can't do that kidney stone operation. We know who's a great doctor for you to go to. There's no delay in that. But if they can do it, they do it, and they do an excellent job. They got you got new wings. They have a brand new hospital from like 5-6 years ago, which is state-of-the-art hospital, which is nice to have. In terms of I think the second part of your question was the graduate medical school.
So the training pipeline for physicians and how your vision for the future of military training impacts that.
As we all know, there's high competition across the United States for quality clinicians. You compete with VA, you compete with the private sector. We do have a special mission that attracts a lot of people. We are doing an overall look at our recruiting. I think the graduate medical school and the pipeline for clinicians needs to be part of that. What can we do, and what authorities can we add that we don't have to make sure that people understand what is special about the military mission? Because there's a lot of people, and a lot of men and women will take big pay cuts to work at the VA because of the mission until they're not treated right, and then they leave. We need to incentivize. We need to better recruit. We need to establish an easier pipeline, because if you can't enter the pipeline quickly, you're probably going to go somewhere else. So we need to look where we need to go. I don't know exactly where it needs to go, but we need to look at that, and we need to say, what is the outcome we want? And we need to back into how do we do that? And there's a variety of options in terms of pay, in terms of recruitment, in terms of partnerships with academic affiliations. It's a challenge here. It's a challenge at the VA. It's a challenge in the private sector. The one thing that we have we do not have the best pay in the world. We know that, right? We do have the best mission. We do have the best mission. And we can attract the right kind of people with that mission. But people have families, people have careers, people have needs, and we have to be sensitive to that, and we do need a better job with it. So let's make that an action item. Let's hook up with Sean Parnell and our folks in P&R, and let's look at what's going on with the overall relook at recruitment. And let's look at that pipeline and see where we are with it, what efforts are underway in improving on that. Because there's a lot of efforts that I'm just not fully aware of yet because there's so many things going on. But that's a question. If we don't manage that, we won't have the skill sets we need going forward. So thank you for asking that.
Thank you, sir.
Thank you for the answer, sir. We have time for one more question, but the folks that are online, please do not go away. We're going to take down your questions. We're going to get them to them. They will answer your questions a little bit further down the road. Yes, sir.
Hi, my name is Dr. Matthew Nunley. I'm the Chief Quality Officer. To kind of piggyback off of the last question, and Dr. Ferrara, one of the things you said earlier, has there been any significant GS employee involvement in some of the right-sizing decisions, and how much feedback are you getting from the deck plate in those decisions? To know that you are aware of scheduling and ERMAC concerns is notable. Would you be as readily aware of that if your wife had not experienced the events herself?
Yeah. Well, thanks for the question. And so the first is, yes, there is deck plate engagement and civil, GS employee participation. Would I know? I do think it's definitely an advantage that, I have that. I think that was part of the reason why when I interviewed with Mr. Hegseth, now Secretary Hegseth in West Palm Beach, maybe part of the reason he asked me to do this job is because I have a very deep involvement, and I know that's really important to him. And so, I think that isn't always the case in people in this role. They have, I think, historically have had variable levels of experience and integration with our system. I want to take advantage of the fact that I have those insights and try to leverage those. And I, like Mr. Selnick said, that's why I think if I didn't have that, I would still be doing town halls. I would still be going out because I'm a firm believer. What I've said at other things is, it's just the nature of a large organization, a large bureaucratic system, that as information filters from the deck plate to the flagpole, it gets filtered, and it's not nefarious. It's just the nature of things. So that's why you have to leave the flagpole and go to the deck plate to be able to get the unfiltered information. So that's so important. So, I do have a secret shopper, but I would be trying to find that information anyway. And I think that's why we're going to answer all the questions. We try to have a very open streams of communication and a lot of candor, because that's how we're going to help, solve I can't solve all the tactical. We're at the strategic level, but we can push those out. And one of the things, we've talked about doing is empowering people at the MTF level, at the DHN level, to be able to be greater decision makers. That involves accountability. Like Mr. Sloan, we shouldn't be promoting people who don't want to make decisions. We should be promoting people who want to make decisions. So give them the opportunity to make decisions, give them the opportunity to succeed, knowing that if they don't do a good job, they might be asked to find other work. That's okay. But that's the part of accountability. I'm not saying that in a bad way. I'm just saying we want to promote people that can, perform well and perform decisively and, on mission.
Thanks, sir, for that answer. Captain Rosario, you're back up.
Actually, Captain Austin, if you wouldn't mind. Gentlemen, I still think that the team was relatively gentle in some of the questions that were asked. I know that one question that came up, if you would entertain it for 1 second, was the question about a decision on the probationary employees. I don't know why they weren't as bold to bring it up, but that was a question that was circulating before you walked in. So any updates on the decision on any exemptions that were made for medical personnel that were affected by the probationary employee cuts that are happening throughout the government and specifically the DOD?
Yeah. My understanding is that we were not cutting any probationary medical. Now, we do have a freeze going on, and we are in the process of bringing up the exemptions for the freeze, but my understanding was that we were not cutting any probationary medical, that they were exempt.
Did you all hear that?
Where we're at is that, and I've made this my own comment at a town hall, I've not been directed to terminate a single probationary employee yet. That said, I think the discussion is still happening at the headquarters level as to which employees exactly are in a flat-out exemption category, and then what additional authorities there might be at my level to designate somebody as exempt. But until otherwise directed, I'm holding on to all my probies, so.
If that changes, let me know.
All right, sir.
If that
Will
changes,
do.
let me know.
Okay, so we actually have a gift for both of you. We've traditionally done coins or things like that, but we have the Walter Reed Society. You and I were talking about donors earlier.
Yes.
We have the Walter Reed Society, which is an incredibly charitable organization dedicated to sort of the memory of Walter Reed. And they often give us things that we need and can't get through traditional methods. So one of the things, the current president of the Walter Reed Society wrote this book, and this is Yellow Jack. It's actually the story of Major Walter Reed and the fight against yellow fever. So I wanted to share, it's autographed by the four of us, the tetrad as we call ourselves. It says, "Walter thanks you," and we've all signed it just as a memento of this visit and my sincere appreciation for you both taking the time to be here and have a very frank conversation with my team. So you're the first recipients of our new command gift.
We are
Very
honored.
good.
We
You
are
are-
honored.
All right, I'll get rid of this, so
Thank you.
We are honored.
so much so.
Thank you.
Privilege. All right.
Thanks, Chairman. Thank you.
Folks, this concludes today's town hall, but let's just give a round of applause to this gentleman who took the time to come. It certainly takes leaders to stand in front, and gentlemen, we thank you for doing so. We certainly appreciate it.
Thank you. It's been an honor to be here.
Thank you very much. Attention on deck. Carry on.